Hi, everyone. I'm Dr. Aakriti Gupta, Executive Associate Editor for JACC and an interventional and structural cardiologist at Cedars-Sinai Medical Center. I'm very pleased to welcome Dr. Joerg Hausleiter, who's Professor of Medicine at LMU, University of Munich in Germany. And we're here to discuss one out of many publications that are coming out in JACC simultaneously with TCT, which is really about the real world experience with the PASCAL device for tricuspid tear. So, Dr. Hausleiter, why don't you introduce the study to us a little bit, and then we can go in a little bit deeper into its practical implications.
Sure. So the study we are publishing today is the PASTE registry. The name PASTE stands for PASCAL for Tricuspid Regurgitation, a European registry. And this is an investigator-initiated registry, which has been performed in a multi-center, regional and prospective fashion. It is an observational cohort study, which included more than 1,000 patients with severe tricuspid regurgitation who have been treated with the PASCAL system for an edge-to-edge repair. We initiated this registry in 2019, and 16 very experienced European heart valve centers participated in this trial and enrolled their patients on a consecutive basis into this registry. The particular aspects of this registry are that there have been no dedicated in or exclusion criteria. So in fact, it's an all-comer real-world study. And the other aspect, which I think is important compared to other registries, is that we performed a central image analysis of all echocardiograms for the study. So at baseline, the procedural aspects, but also at discharge and the follow-up, so that we have a very similar and high quality assessment of the echoes of each patient.
So to clarify, were you including all consecutive patients that were being treated with the PASCAL device for tricuspid tear?
Yes, that was the goal, that we are treating and enrolling consecutive patients without any in or exclusion criteria. This is what we asked all sites to do. Absolutely,
and I think
yes.
we should make it clear to the audience that the PASCAL device for tricuspid tear is CE marked and is commercially available in Europe and many countries outside of the US, but it is still not FDA approved in the US and is only being done in the setting of a clinical trial. So that is why the findings of this study would be very important for the US people to take into account as they take all of the data for tricuspid tear into consideration, including from TriLuminate, Tri.fr, and then we have registries for TriClip, which is the Abbott device, which is FDA approved in the US. So those are some great things you pointed out. The strengths of the analysis being that we have a core lab echo analysis and that these were consecutive patients. But I think we should keep in mind that it was the operator's discretion, right, whether they wanted to use TriClip or PASCAL, and they would have been included only if they got PASCAL, correct?
Yes, yes. We only included those patients if they have been treated with the PASCAL. Most of the participating sites, in fact, are using only the PASCAL device, so that there is probably not too much of a selection bias, but in the end, we cannot rule it out.
Absolutely. So, I know this is a study across 16 centers, and we were able to have a very impressive amount of about 1,059 patients. So, what are your headline findings from this registry?
Well, first, I think looking at the patient characteristics and comparing these to the trials you already mentioned, Triluminate and TriFR, for example, there are a few aspects which are really representing more the real world patient population, at least the ones we are seeing in Europe. So, for example, that we had patients with CID leads, which represents more than 25% of patients. We have almost 80% of patients having reduced kidney function, so GFR below 60, or, for example, regarding their symptom burden, 84% of patients were classified as being in New York Heart Class 3 or 4, so significantly more often than in very symptomatic than in those trials, or previous heart failure hospitalization with 58%, so very sick patient cohort. In terms of the procedural success rate, we looking also at the TCT definitions, the implantation success and reduction by at least 1 degree of TR. This was obtained in 95% of patients. And the other goal, to reduce the TR to at least moderate or less, was also achieved in almost 90% of patients. So overall, the intraprocedural success rate, according to the TCT definition, was 85%. So at a very high level, we obtained a very good result in terms of TR reduction. Importantly, these results were achieved with a very high safety profile as compared to all other edge-to-edge devices being used in the field. When we're looking at 30-day outcomes, the all-cause mortality rate in this elderly patient population was only 1.3%, and the combined rate of heart failure hospitalizations or mortality at 30 days was 2.7%. Redo interventions, either re-intervention or surgery, was also very, very rare. Only 0.5% received a second procedure in the first 30 days. So this speaks and underlines the high safety profile also of the PASCAL device, which is very similar in terms of the safety, also to the trials which we already mentioned. But here again, it's a different patient cohort. It's an all-comer, a much more sicker patient cohort, still having a very, very good safety profile.
That's wonderful. And I think one of the relatively novel aspects of this study that I found was that you also were able to show that with increased operator experience, the outcomes were even better. And I think that's a lesson for all the new technologies we introduce in our armamentarium. Normally, when we conduct randomized control trials of one device versus a control, which is something that's available in the market for a decade, people know how to use it. When we compare these devices, sometimes we can run into an issue where a new device will not perform so well, and part of it is also operator experience. And I think the study demonstrated that very well.
Yeah, I think you're highlighting a very important aspect, a new finding in this registry, that experience really matters. And we looked at the median of procedures, number of procedures per year, which was 21 PASCAL procedures per year being performed. And if you were above this threshold, you had a significantly higher intraprocedural success rate, you had less complications, so a higher clinical success rate at 30 days, but also a higher success rate at 1 year and significantly less SLDA. So a very important aspect is not only that the procedural time is perhaps a little bit shorter, but also in terms of relevant patient outcomes, it's really shown that for the first time that experience matters, which is a call for centralizing probably such complicated procedures to less centers, but having a higher experience at those centers.
Absolutely agree. And I'm going to ask you the hot burning question in the tricuspid space, given that you're an expert. How do you envision the evolution of TEER devices versus TTVR devices? This TCT is going to be very important, as we're going to see the 1 year results of the TRISCEND. We're also going to see 1 year results of the full TRILUMINATE cohort, and obviously your study. So how are you thinking this future of tricuspid therapies is going to evolve?
It is probably the $1 million question. Nobody can answer probably with a great confidence, but it really depends. I think if a patient is being treated in a high volume center with a lot of experience, then I would envision that many patients can be treated very effectively and safely with an edge-to-edge repair technology, knowing that these procedures have a little bit better safety profile than replacement technology. If the technology is being spread in too many sites and the experience might not be as good as in high volume sites, then perhaps a valve replacement might be a better option for many patients because it achieves to a higher degree a more significant TR reduction. And we do know that TR reduction translates into the improvement in quality of life. If there is a better device for most patients, or a better strategy, not a device, better strategy, repair or replacement for most patients, that can probably only be answered in prospective randomized clinical trials.
Agree. And I think one of the other really important aspects of your study that I really liked was that you also identified independent predictors of procedural, not failure, but suboptimal procedural success, like, with larger coaptation gaps or leaflet tethering or tenting height or presence of a transvalvular lead. And some of those things, I think, will be factors that will push operators more toward TTVR if TEER was not going to be successful. But I think the question of whether if all things being equal, if a patient is a candidate for tricuspid TEER or TTVR, what is going to be better, I think will have to be individualized, but also studied in randomized control trials. And I'm hoping one of them is underway.
Well, not that I know of, but perhaps you're going to start one very soon.
In at least in design stage, so we'll see where that goes. All right, this has been a tremendous pleasure, and we wish you luck for your presentation at TCT and look forward to seeing you there.
Thank you very much. See you soon.
Okay, take care. Thanks.